Good morning, good afternoon, and good evening, everyone across the world. My name is Manu Jain, and today I'm going to talk about live interactive in vivo, but remember non-invasive technique, which is called reflectance confocal microscopy that we are using for diagnosis of skin cancer. And I'm at Memorial Sloan Kettering Cancer Center in New York, but today I am actually I don't have a conflict of interest, but I'm talking from Ahelia Fort. As you can see, this is a suite we are right now, and this is the beauty of this digital world. But I hope the connection stays stable, and I'm sitting somewhere inside here and giving this talk. Hopefully it was a daylight and I could have shown you more. So welcome to the digital world. First thing, skin cancer incidence. So what is the skin cancer incidence? We know that skin cancer is one of the most common cancer in the United States and also worldwide. There are three types of skin cancers: basal cell carcinoma, squamous cell carcinoma, and melanoma. We all hear about melanoma so much, and it is because it's one of the deadliest cancer, but its incidence is not that high, but it's deadly. Then there are other two cancers like squamous cell and basal cell. They're very frequent, and most of the Caucasian population, 1 in 5 Americans would have one of these cancers in their lifetime. So that's very worrisome. What are the current methods for diagnosing skin cancer? So when you're in dermatologist or you're visiting a dermatologist will give you an entire checkup of your body or your skin and would identify a few lesions. And after that, they will take out this kind of a magnifying glass and try to see even more detail, like these kind of patterns of pigmentation, vascularity, and make a diagnosis whether this lesion is benign, that is, it may be left like that, or it's malignant, it should be biopsied or treated. However, this technology, which we call dermoscopy, doesn't let us see the tissue at cell resolution. And that's the reason that although it can detect cancers at a high level, but not all that it detects is cancer and their specificity is low. That means a lot of biopsies are still performed, and biopsy is actually becoming, unfortunately, a defensive practice in skin cancer care because no dermatologist does want to miss a melanoma and be sued later. So millions of biopsies are being performed annually, and the cost is enormous. Although you see it's not big for one biopsy, but it is enormous at the end of the day. And the worst scenario is, or good for the patient or bad for the patient, is almost 80% or 60 to 98% of these biopsies are not even malignant. So we are performing unnecessary benign biopsies, which is causing pain, bleeding, scar, and trauma to the patient. And when they are located on the cosmetically sensitive side, like face, genital areas, etc., patient doesn't like it. And when you send these biopsies to a lab for histopathology evaluation to be looked at cellular resolution, you have to wait for a long time to get your report back. That creates anxiety, and that's not good for the patient. And also a doctor cannot actually give you any management immediately. So unfortunately, to many of the patients, this is what happens. They become cysties after digging a lot of cancers. The thing is, can we avoid these biopsies and what their drawbacks? And still, we can make a diagnosis at cell level and give that diagnosis at bedside. That would be awesome. And that's the new era of non-invasive diagnosis, which I'm going to talk about. And this is called reflectance confocal microscopy. So it is a non-invasive imaging technique where you can see skin at cell level resolution without even cutting out the skin. Okay, without performing biopsy. We call this technology as virtual biopsy or virtual pathology. And as it is virtual, there's no pain to the patient. And the advantage is the bedside diagnosis can be rendered and a management can be made on the same day, saving a lot of pain, trauma, and money at the end of the day. Now, these devices look like something like this. So this is called Vivascope 1500. What is happening here? This is my technician who's serving as a guinea pig. And what we have done is this is a Vivascope 1500, and it's a clinical device. So it's not a researchy device. And this is attached, there's a microscope inside it, and it is attached to the skin. And now it is over the lesion, and you can actually see the histology or the cell level information right here on the monitor in the real time. This is another device, which is also reflectance confocal microscopy. And we call this as a handheld device. See how small it is? So you can actually image the lesions located on nose, earlobes, where you cannot put this bulky device. So bottom line, these two devices are commercialized and we have it at MSK. We are using it for years now. How the skin looks like, it's very interesting. Even patient wants to see that. You see, we are at the dead layer of the skin right now. So it starts looking at the skin from top to bottom. Okay, so the first layer of the skin is dead and it is very bright on confocal microscopy. So when I play this video, you'll start seeing that these dark holes appear. We are going into a nucleated layer, which we call stratum spinosum. And I'm not giving a lecture of histopathology or confocal microscopy here, but the bottom line is how beautifully we are going from top layer to, and this is a junction where actually most of the cancers originate. And do you see these flickering cells? These are blood vessels. So it's a beautiful phenomena that you can see in real time while imaging. And now it's going in the dermis where people have collagen and they want to put collagen creams, etc. So it goes up to 200 micron. Okay. Now, as I said, this is not a game or a tool or a researchy tool. It is in the United States got CPT codes in 2018, and we are billing patients right now. So that is a good news because it's clinical. How is it being used is interesting. As I showed before, when patient walks in, the dermatologist look at the clinical picture, puts the magnifying glass, and then if they're not even sure what it is after all this, they will do confocal. And now what will happen? If this confocal shows it's malignant, they will biopsy it. If it shows not malignant, no biopsy is done. So we are using confocal microscopy for differentiating benign from malignant and triaging lesions. What impact it has? That specificity has increased twice, meaning to say now lesser benign biopsies are performed. So this is a really good thing for the patient and everyone. Now, some of the very basic examples I just want to show is how it can differentiate facial pigmented lesions. So face is a sensitive site. And people really want to be sure whether this is lesion benign or malignant, because if you biopsy a lesion and later it comes back at benign, okay, you'll be relieved, but you have a big scar on your face, right? Nobody wants that. So these are two examples, one on the left. This is a dermatoscopic picture. One on the right is also a dermatoscopic picture. They both look very suspicious because of the features here. On confocal microscopy, we confirmed that this lesion is just a benign lesion, which you call solar lentigo lentiginous because of sun exposure. And this was a melanoma because you see these big cells here. And this patient had a biopsy. So that's how it's helping in clinics. And also it can help in like lightly pigmented lesions, see here and here. And on confocal, you're seeing this is just a mole, right? These are just the cells of the mole, and these are individual cells. And here it's a tumor, it's a basal cell carcinoma. So this patient would have a biopsy. Again, a very interesting way confocal is being used is monitoring treatment non-invasively. So if somebody is applying a cream for any cancer, and then you want to see whether the patient responded, you have to do a biopsy. But with confocal, you don't have to. So you can actually monitor with confocal microscopy. Here is an example of an 83-year-old gentleman who had this ill-defined lesion, which looked very irregular. We did that magnifying glass dermatoscopy, and it doesn't look very nice. We did confocal, and it looks really bad because these are just the dendrites or of the malignant cells, which are rising up in the epidermis, which we call pagetoid cells. And we also call this Medusa head kind of an appearance. And if there's any histopathologist here, can identify this as a melanoma. This patient actually received radiotherapy, and after a few cycles of radiotherapy, we performed confocal again and see how these dendrites are gone. So bottom line, this is very helpful. Now, how we are using it at MSK is we are diagnosing patient at the bedside. What does it mean? If a clinician has a patient, he or she will send this for confocal within our department, and an expert will read these images and give the diagnosis there and then. So the whole procedure happens within 20 minutes. And that's excellent because the advantage is you can also actually store these images in the cloud-based, but you can also look later, but we do the bedside approach. And the advantage is you can give immediate diagnosis to the dermatologist, patient is relieved, and immediate management can be made. Bedside diagnosis is a bit challenging because, as you saw, these images are black and white, It's a new technology, very few experts currently to read these images. But what is the role of teleconfocal? RCM is a digital technology, right? We are taking images digitally, and so they can be shared, right? And again, another thing is you can send it through cloud or even see what we do, our approach. So the standard teleconfocal scenario is store and forward method. What happens is a clinician or dermatologist setting identifies a lesion, send for confocal microscopy. These images are sent to cloud, and then it can be sent to experts sitting anywhere in the world. And the expert generates a report, sends it back to the dermatologist. Wow, this is good, right? Because the dermatologist doesn't need to learn to read these images, and that's a relief. However, the problem is this expert might not have time immediately to look at these images, and then by the time the report comes back, the patient has gone. So there's no immediate management there. And so it just defeats the purpose of confocal microscopy. Our approach is live interactive, which I'll show you very quickly. In this scenario, which we are testing, we have a dermatologist, and the dermatologist schedules a patient for a confocal session, and no images are sent through cloud or nothing, but expert is actually brought through the WebEx. So the link is shared with the expert, like I'm giving a talk right now. And the expert will be with the dermatologist, can talk to the patient and give a diagnosis at the bedside. And the advantage is obviously you can train new technicians how to acquire images, because in digital world imaging, especially, it's a major concern. If you get bad images, you cannot make diagnosis. We call GIGO. Teach physicians how to read, because they just don't want one report, but they want to know how we came to a diagnosis, which is important. And the requirement is obviously, if you have a high-speed internet connection, that's great. And if you're in a similar time zone or a favorable time zone, that's great. Advantage, you can give bedside diagnosis immediately, and you can actually do the management. So we are all in the digital era. We are like kind of doing all the tele thing. And this was one session actually we recorded. This was with a clinic in LA. And I'm sitting in Terrytown in my home on a weekend. Patient is scheduled. And this is the screen of that microscope. And they are sharing the images right now with me. And this is the lesion, how the lesion looks like. Now I'll play.
Sorry, Manu, could I just ask you to wrap up in the next sort of 60 seconds or so, as we're hitting the time mark?
Yes, I'm almost done. So this is the beauty. You see how you can see that, and they can pass me control, and then I can actually make a diagnosis, and I can forward all this very quickly. And I'm making a diagnosis. I can tell them in real time, and everybody's happy. Okay. So this was the group that I mentioned. We published this Pearl, and now we are actually launched a multicentric study, and we'll be doing across the world. People are making teleconfocal, and they're making portable devices. As we were just discussing in the previous talk, we have mobiles. Eventually, the idea is we'll make small devices, which will be cheaper, and then we can read it on a beach anywhere in the world. And finally, AI will come to help us in integrating these algorithms. And thank you, Julia and the team, for your kind invite.
This is just amazing work, Manu, and I mean, absolutely revolutionizing the way that diagnosis is happening in this area. So thank you so much for your time coming on and sharing everything with us.
Thank you very much.
On behalf of the whole HITLAB team. So up next, we have Jim McGough, who's going to be talking about the digitization of pharma. So for the attendees in the audience, I would just ask you to jump into that session from the main agenda page. See you in a second.